Thanks, Ian. Okay, so thanks very much for the invitation to speak. I'm going to take a vastly, probably different direction, really. This is much more clinical based, and I'm trying to keep it as near now as opposed to far ahead in the future. So what I'm going to try and go through is essentially 3 diseases that are all neurological, and each of which have opportunities for collaboration between physics and medicine. So multiple sclerosis, the first one. Relevant, 2.3 million people worldwide have this disease, 200 new cases a week in the US, and in Ireland 9,000 people live with MS. And St. Vincent's has the highest cohort of people living with MS under its treatment in Ireland of any hospital. Patients are frequently imaged, and they're imaged initially to make the diagnosis, and they often have to be imaged twice to make the diagnosis. And then they're imaged to detect disease activity and response to treatment. So their therapy institution, changing of therapy, etc., is very much determined by clinical, but very strongly determined by imaging features as well. So this is a patient with MS here, if I can show you this. These are classic Dawson's fingers. So this is demyelination along the veins in the brain, and that's why they're orientated in this direction. So the question is that when you scan someone with symptoms of MS, you have to wait to see if they disseminate in time, meaning you need to wait for another episode of activity which would appear as a new lesion. So if we did a second scan of this patient and this was a new lesion, that would be dissemination in time. That's a diagnosis of MS. That means you might have to wait 6 months before we can give someone a diagnosis, which means you have to wait 6 months before we can treat the patient to prevent future disability. So the question is, can we make the diagnosis straight away rather than waiting for a new lesion to appear? So one of the features of MS is this central vein extending through the lesion. And here, if you look at the image more closely and use susceptibility imaging, you can see a central vein going through it. This helps differentiate it from ischemia and from migraine. And one of the studies that we're enrolling in at the moment is a prospective study of patients with known diagnosis to see how many of them have this imaging finding. But really, we can go much further than that, and we should be able to quantify the imaging that we're looking at. Rather than just use our own qualitative view of what we see, we should be able to use advances in radiomics to try and quantify the abnormality, to improve the accuracy, and to really increase the predictive power of what we're seeing, which could convert into a clinical decision support tool for when we look at these images in patients with MS. Differentiating MS from a non-MS lesion, that might seem very, very simple, but it's very, very complicated. This is somebody with ischemia. This is somebody with multiple sclerosis. They essentially look the same, oftentimes. And a particular case of that is that if you have somebody with multiple sclerosis, they're not immune to developing ischemic lesions. Ischemic lesions are very common. Everybody who has an MRI brain scan over the age of 40 will have dots in their brain. So if you see a new dot in someone with MS, we assume it's MS, but that's incorrect because we know that people get ischemic lesions. So that means that we may change somebody's treatment who's on MS because they have a new ischemic lesion because we've assumed it's demyelination when it isn't. So being able to differentiate those two entities is hugely powerful. This would lead to precision treatment, right? The correct treatment in the right patient at the right time. If you look at this patient, what about predicting new activities? This is the first MRI, query MS, new lesion here in the brainstem. That means dissemination in time. That's equals a diagnosis of MS. But can we predict that that was going to happen? Can we look at this MRI and use radiomics and analysis of the imaging features to say, actually, in 6 months' time, a new lesion is going to appear here, and then can we make the diagnosis at the start? If we could institute treatment straight away, and we could reduce disability in the future. I had to put a black hole in because everyone's mentioned space, but in MS, we have black holes too. A black hole is where you get irreversible destruction of axons. And that predicts disability more than a lesion that doesn't become a black hole. So not all lesions become black holes. So you need to know which ones are going to, and then you can predict further disability in these patients. So along with that, we need to have a way of analyzing these multiple scans over multiple time points. So we're developing at the moment an automatic segmentation tool so we can subtract MRIs, and then it'll just show us the new lesion, which is here on the patient's temporal lobe. Okay? But on top of that, we really need to employ machine learning and develop algorithms so that we can do that in a much more accurate manner than is possible. So if we combine radiomics, we combine subtraction, we overlay machine learning, we develop a clinical software, we might end up with a software that tells us, well, here's a new lesion, but it's ischemic, so don't worry about it. Here's a new lesion, and this is going to be a black hole, so worry about this a lot, because this is going to predict the person having significant disability. And here's an area where there's going to be a new lesion in 6 months, so you should worry about that too. So that's the potential. The other thing is very important in people with MS is atrophy. They get cognitive impairment, loss of grey matter. It's a huge concern. It's an area that therapy hasn't targeted for these patients, and we need really good tools to measure grey matter and measure it over time as it changes. We can also use molecular imaging with FDG PET to show cortical dysfunction, as in this area here where there's reduced uptake. And also, as someone said earlier on, to make the invisible visible. This is invisible on the PET scan, but this is when you compare it to a normative database and you show that there's inflammation throughout the white matter in the brain. So this is another marker of MS. Dementia, and I've only got 2 slides on the next 2 things, so I'll run through these. But dementia is 50 million people, 50,000 in Ireland. It's a massive problem, 7% over the age of 60. And if you look at this, you go from Alzheimer's pathology, which you can't tell you have, to MCI, which is a little bit of memory loss, to frank Alzheimer's, where it impacts your daily life. 20% of the population over 60 have this mild cognitive impairment, and a third of those will convert. So what we need to know is who's going to convert, and we need to try and predict that at the outset. So in the clinic now, we can measure amyloid in the CSF, we can measure tau in the CSF, and we can look at neuronal degeneration with FDG. So we should be able to combine all of these pieces of information to determine who is going to get Alzheimer's, who is not going to get Alzheimer's, even if they have a cognitive impairment. So can we look at a normal MRI brain and see signatures for amyloid deposition? Can we look at a normal MRI brain and see signatures for tau deposition? Can we predict who's going to convert from MCI to Alzheimer's? And can we overlay machine learning to increase that accuracy? Last one is Parkinson's disease, 10 million worldwide, 8,000 in Ireland, similar numbers of patients with MS. Loss of nigrosome 1 in the brainstem is the cause of it. And if you look, actually you can see it here, this is called a swallow's tail. This is a normal appearance. And when you lose that high signal in the center, that's what happens when you get Parkinson's disease. This is research-based. This isn't used in the clinic. What's used in the clinic is a cocaine scan, which is called a DAT scan. You bind cocaine receptors in the brain. And this is a normal scan, and this is an abnormal scan. This scan costs about €300. This one costs about $1,500. If we can use feature analysis to make this diagnosis more accurate, we don't need to do this one. So we can try and use radiomics and machine learning to improve diagnostic performance, predict drug response, predict cognitive dysfunction in Parkinson's disease, and also we can't separate out Parkinson's from patients who have Parkinson's plus syndrome, such as progressive supranuclear palsy, with this test, but maybe we can with this test. So these are other future collaboration opportunities, and thank you very much.